good olden days when there were no biochemistry or pathology tests. So they used to say if someone has sugar or sweetness in the urine, and then they used to say that there is honey in the urine, so that name was given, diabetes mellitus. The problem, whether it is type 1 or whether it is type 2, that is hyperglycemia. Hyperglycemia. You can add more types, but basically for pharmacology, we classify the diabetes mellitus into two types. Why we classify it into two types? Because the medications or the drugs, they will fit in these two categories. And you also know that one is called insulin dependent and the other one is called insulin independent. But this classification may not work every time, as we will see here. Or you can say more appropriately, one type of diabetes mellitus is insulin deficient and the other one is insulin resistance. Insulin resistance. Insulin deficient means as these beta cells, islets of Langerhans in the pancreas, they are unable to synthesize insulin. So when they are unable to synthesize insulin, we need insulin. As I told you, this is the key. Like we have such big room, but if we don't have key, we cannot enter into the room. So the insulin is like this. So what will happen to the glucose? It will wander in the blood and plasma. And when it will wander in the blood and plasma, the blood glucose level goes up and up. So that will be hyperglycemia. To make it simple, again, insulin deficient, where the beta cells of Langerhans, they are unable to synthesize and produce insulin. So that is what we say absolutely no insulin. And just 100 years back, 1 century back, there was no treatment for diabetes mellitus type 1. You, Dr. Fatih might have told you the story.
Yes, because
Yes, people used to die. People used to die because there was no treatment. Then pigs came, then bovine came, and then now we are using human source DNA recombinant technology. But the bigger problem, because type 1 is fortunately less common and it is related to genetics, families, and sometimes unfortunately what we say, maybe discussing with Dr. Abdurrahman, autoimmune. So when there is autoimmune, you cannot do anything. Anyone can be attacked by own antibodies. More females, but males can also suffer from this autoimmune induced diabetes mellitus. The important one, that is type 2 diabetes. As you know that we are passing through modern age, every facility is with us, but we are having a big challenge. What is that big challenge? That type 2 diabetes mellitus, obesity, overweight, that is epidemic. You go everywhere, people are concerned about weight gain, whether males or females, sports, gym, this time, fitness time, all these things are for this. Why? Because we are facing this big problem. What is happening that ultimately people are suffering from type 2 diabetes mellitus. Why they are suffering from type 2 diabetes mellitus? Here we say in type 1, there is no insulin, what I told, that absolutely no insulin. So that you should keep in mind because it will help us when we will discuss insulin in the treatment. The second one, that the insulin that is produced, that is not enough insulin. The beta cells of Langerhans or islets of Langerhans, they are producing insulin, but the amount of the carbohydrates or the food that is going, that is much greater. That is much greater. So the amount of the insulin, for example, you can say it is, because it is measured in units, it is 100 units. And you take, for example, 500 grams of carbohydrates. So there is a big difference. We have a formula, but that is biochemistry. I'm not going into that. You don't like biochemistry. You like it, but not too much. Okay, so the point is that there should be some appropriate, because how much insulin and how much carbohydrate sugar you take, so that makes difference. And for this reason, you see, when someone is diagnosed with diabetes, the first thing that is diet control. Say goodbye to sugar. Why? Because the insulin that the body is producing, that is not sufficient. You might have discussed C-peptide. Where is C-peptide? Maybe in last lecture it should be there, because it is part of the insulin. Okay, so body, the beta cells, they are producing insulin, but what I told you, it is not sufficient for the amount of carbohydrate that you or we take. This is first situation. Second situation, that is more serious, especially when we are overweight. That is insulin resistance. Insulin resistance. By some reason, we don't know exactly, insulin does not allow the sugar to enter to the cell. We can understand it like when you go to Haram, especially during Ramadan or Hajj, then they don't allow sometimes, they say you cannot enter. Although, when you see on the screen, there is good space in the Haram, but still they say don't, you cannot enter. The same happens here. Insulin is there. Insulin is standing at the receptors, as you mentioned, insulin receptor substrates. Insulin is there, but insulin doesn't open the key for the glucose to enter into the cells. So what is that called? Insulin resistance. And that is more common and serious. Okay, so in type 2 we have two types of problem. One, that the beta cells don't produce sufficient insulin. This is one. Second one, insulin is there, but insulin does not allow sugar or glucose to enter to the cell. So that will be insulin resistance. Treatment is same. Treatment is same, but only difference that at one we have insulin and the other one we don't have insulin or less insulin. Okay, how we can fix this? How we can fix this problem? Hyperglycemia. How we can fix this problem? Hyperglycemia. You might have discussed in physiology, maybe pathology and biochemistry. Ultimately means finally, akhir. Any patient who is diagnosed with diabetes and doesn't take care, what we mean uncontrolled, he has to take insulin sooner or later. Sooner or later, whether he is suffering from type 2, even if he is suffering from type 2. So one thing that you should keep in mind, if you get question on your exam, type 1 diabetes mellitus, only insulin. There is no if and but. Maafi kida kida. Only treatment for type 1 diabetes, the answer should be insulin. The answer should be insulin. We don't have any other option. In case of type 2, yes, we have options. But what I told, that we will go ultimately, if the hyperglycemia is not well controlled, to insulin. Okay? So insulin is replacement therapy. This is replacement therapy, as we discussed in case of Addison's disease, glucocorticoids and mineralocorticoids, when there is no cortisol or less cortisol and less fluorocortisone or aldosterone. So what we do replacement. The same here in the beta cell when there is no insulin, then we will replace it. This is first one. Second one, decrease glucagon and decrease gastric emptying. Glucagon. Glucagon means, glue means glucose, very good. Gon means gun. Because they are opposite to each other. You see, when insulin comes for the glucose. And glucose gone, then this hormone is coming. Glucose is going, when it is going, when insulin is there. Insulin is there, the door is open, glucose enters into the cells. So this hormone will start to release. So it keeps balance. Although insulin is greater as compared to glucagon. But glucagon is the hormone that helps us to get the glucose. For example, glucose is gone, so what it will do? It will send message in the body where the glucose is present. Where the glucose is present? Like during fasting, you don't take anything the whole day and still you are doing fine. And you know that we need glucose as energy source. So from where this glucose is coming? Liver, very good, mashallah. So it will send messages, Dr. Mafi glucose, send glucose. So promote the processes of glycogenolysis, bring glucose. This is first one. But if someone is fasting, so he will not take the out source. So it will be from the liver. So, but we don't want glucose. We don't want glucose. So these drugs, they will suppress glucagon. They will suppress glucagon. Why? Because when glucagon is stimulating, it tries to keep our blood glucose level up. It tries to keep our blood glucose level up. Why? Because the body needs, and it will send message to the liver that send it. First one. Second, decrease gastric emptying. Gastric emptying, as we discussed in GIT, the stay of the food in the stomach. So if the food stays for more duration in the stomach, good or bad? Bad. But there is a condition where we want that the food should stay more in the stomach. Why? Because after stomach, where it will go? To the small intestine to absorb. And we want to delay absorption. So when the food is delayed to absorb, it will help us to decrease the blood glucose level. Why? Because carbohydrate, it is digested, but when we delay it, stay in the stomach. For example, normally it takes 1 hour. By increasing the gastric emptying, it will stay for 3 hours. So staying for 3 hours means that the blood glucose level will go up after 3 hours. Why? Because it is in the stomach. First it will go to the intestine and there it will be absorbed. So by two mechanisms, it will help us to reduce the blood glucose level. First one by suppressing glucagon or decreasing glucagon, and the second one that is by the delaying gastric emptying. Okay, now we have two groups. One is called incretin analogs, exenatide, and the other one is amylin analogs. Again, amylin is here. Dr. Fatih is made things easy for us. Both incretin helps to increase the insulin. What type of insulin? Glucose dependent. Whenever you take a glucose source or carbohydrate source, it will send message to the beta cells, release insulin. Release insulin. So that is called incretin analogs or exenatide. The second one is amylin analogs or pramlintide. that will the same, it will send message that release insulin and suppress the appetite, hunger station, because when our glucagon is stimulating, glucagon also stimulate our appetite center. Glucagon is also stimulating our appetite center, that we need food. It is helping to get the glucose from the liver, but at the same time it arranges to bring more food. So you send message to the hunger station 24/7. So that is here, incretin and amylin suppress the hunger station. Send message we don't need food. Glucagon send message we need food. They send message we don't need food. Confusion, yadaktu. What we will. Today all the university is free. No one is there except our college. Because to the other message is, today Amir is coming, don't come. For us, no, you can come. Because this is medical school or health sciences school. So here the same situation. One is sending message that send food. The other message goes, don't send food. So whichever is strong, that message will be taken. So the message of the incretin and amylin is stronger, so it suppresses glucagon. So that is the second mechanism. But the bad thing, or you can say the important thing, they are injectables. So insulin is injectable, as we will discuss in detail, and these drugs that act on the incretin and amylin, they are also injection. Recently, they have one oral, but it is very expensive. And those who are planning to reduce weight, they are also very effective. They are also very effective. Why? Because they act on the, what we say, glucagon, like type 1 peptides. Now, the next one is inhibit breakdown of endogenous incretins. Endogenous mean that the body itself produces incretin. We have enzymes that breaks down this incretin. While we say that incretin is good for us, in situation where the patient is suffering from diabetes. Why? Because incretin helps to specify the food type. It specifies to help food type that this is glucose. Otherwise, when we start eating, the islets of Langerhans beta cell, they start to release insulin. But incretin helps to differentiate that this is carbohydrate source, or this is glucose source, this is protein source, this is lipid source. So that is good for us, especially when we are suffering from hyperglycemia. Why? Because then it will send insulin to act on. Now, but naturally, what is happening that there is hormone, there is enzyme that acts on the incretin and it breaks down the incretin. So the incretin will be broken down. What is that enzyme? That is called DDP4. D for diabetes, D for disease, and P for patient. Isn't biochemistry? DDP4, dipeptidyl peptidase 4. Dipeptidyl peptidase 4. You don't need to recall the full name, but at least you should know. This is the enzyme that causes the breakdown of incretins, endogenous incretins. So what we do? We block this enzyme. We block this enzyme. So these drugs, they are called DDP4 inhibitors. DDP4 inhibitors. So they will inhibit the enzyme. So when the enzyme is inhibited, what will happen to the incretin? It will not break down. Why? Because this enzyme is breaking down. So when enzyme is not there, this DDP4 enzyme is blocked. what will happen? Incretin will increase. So that is the mechanism. Good thing about this, and you will see almost all diabetes patients take it, that they are oral. Tablets are there. And all of them, they end by the suffix gliptins. And one of them is sitagliptin. So that is its mechanism of action. When we were studying pharmacology, there were only three groups. One insulin, one metformin, and third one sulfonylurea. Today we have a very long list, and it is continued to increase. Why? Because you know the research that is going on in the world. 50% of research is on the diabetes. The rest in other things, 50% research in medicine, drugs, all is on diabetes. Every year we get new drug. Why? Because this is epidemic. We are facing really very big problem in this type 2 diabetes induced hyperglycemia. Okay, now we come to this. Stimulate glucose uptake and inhibit liver gluconeogenesis. So it is against glucagon. Why? Because glucagon send message to the liver, produce more glucose because we need it. This drug, it says don't produce. It inhibits the gluconeogenesis in the liver. It has no direct effect on the insulin. Here, no insulin. It only acts on the source that is in the liver. First thing. Second, it helps stimulate glucose uptake. So, stimulate glucose uptake is required in which situation? Where the cells are not responding. We have insulin, what I told, but there is insulin resistance. For some reason, insulin doesn't open the door. Insulin is key, insulin doesn't open the door. So that is resistance. And these drugs, they help to reduce this resistance. So when the resistance is reduced, what will happen? The glucose will enter into the cell. So by two mechanisms, they act. First one, by increasing the uptake of glucose into the cells, and second one by reducing or inhibiting hepatic or liver gluconeogenesis. We will discuss them in detail. Metformin. As if anyone in your family suffering from diabetes, even type 1, obese. Treatment for type 1 is again insulin. Keep in mind. Yeah, but you will see the patient is type 1 diabetes and he or she is taking also metformin. Metformin is for the hyperglycemia to suppress appetite. Sitagliptin and metformin very commonly used in all diabetes patients where there is obesity. Or overweight. Next, increase insulin release. They are called secretagogues. First one, that is, who will help me to pronounce?
Glipizide?
Glipizide is the name, the group. Just I mentioned.
Sulfonylureas?
Sulfonylureas. Now we classify them into generation, first, second, and third generation. Sulfonylureas, like glipizide, they act on the beta cells of Langerhans to squeeze. They squeeze it to release insulin. So they are called secretagogues. Next is miglitinoids, and that is, one of them is ripaglininoid. But mostly we use sulfonylureas. Sulfonylureas are very commonly used oral. This is second drug that is used, third drug that is used orally. And oral drugs in the management of hyperglycemia is for type 2 diabetes. It is for type 2 diabetes. If it is used for type 1, that is only to reduce weight. It is nothing to reduce the hyperglycemia. You will see in today's case also. Then next we will go to inhibit glucose absorption from the intestine. Our today's fight is against biochemistry. Glucose blocked. We don't want glucose from any source. We don't want glucose from any source, because when it stays in our blood, it causes hyperglycemia. Now, what happens? The glucose, the carbohydrates went into the stomach. From the stomach, it is going into the small intestine for absorption. For absorption, there is an enzyme that is called alpha glucosidase. This enzyme converts the carbohydrates to monosaccharides. Now we block this enzyme. So we block this enzyme. Again, we delay the absorption of carbohydrates. Why? Because carbohydrates need this enzyme for the conversion to glucose. And we block this enzyme. So these drugs are called glucosidase inhibitors. Glucosidase inhibitors. And one of them that is called acarbose. Acarbose. Okay? Then next, inhibit glucose reabsorption from the kidney. Again glucose. First, we try to suppress it in the stomach by the gliptins and incretins. Then when we come to the small intestine, again we try to suppress or delay its absorption. And now when it reached our bloodstream, again we try to reduce its reabsorption. So from where? From the kidneys. SGLT2. S for sodium. GL and T2 co-transporter. GLUT T are glucose co-transporter. Good. So this is another mechanism where we block the glucose to be reabsorbed. So glucose will be blocked, and we also block sodium. So when we block sodium, what will go out from the body with sodium? Sodium will go out, glucose is blocked. Glucose will go out, but when sodium goes, who is going? Water is going. Very good. So sodium is going, glucose is going, and water is going. Now, there are again many. They are called glyphosines, and one of them is canagliflozin. Canagliflozin. Inshallah, when you will be in 5th, 6th year, or you will be teaching or starting practice, they will be like metformin today. Today, there is hardly any patient of diabetes mellitus who is suffering from type 1 or type 2 and there is overweight, obese, and not taking metformin unless contraindicated. Every patient is taking. Now the same situation is for SGLT2 inhibitors. And one of the reasons, as you already discussed with Dr. Ali, almost 90% diabetes patients, they also suffer from hypertension. Hypertension, they go very close together. Whenever you find patient of diabetes, type 2 diabetes, also check the blood pressure. More likely he will be suffering from hypertension. And this drug helps us to decrease the blood pressure. Why? Because it is taking out the sodium and water like diuretics from the body. Okay? They are good, very good drugs, but there is one problem with these drugs. What is that problem? That it causes GTI, not GIT, gastrointestinal tract, GTI. G for not gastro. Granular. G. G is used, one in gastrointestinal tract, the other G is used in kidney. What?
Liver.
Okay. No, system. Kidney is part of renal system. Our kidney is part of genito-urinary system. So here it causes genital tract infections. Genital tract infections. Genitals, you know, reproductive organ infection in male and female. That is one of the important problem with these drugs. For this reason, we cannot use for longer duration. But they are working on it. But up till now, the problem that we face with SGLT2, that they cause GTI, or genital tract, or genitourinary tract infections. Okay, next we go to the group synthesized cells to insulin effects. Synthesized cells, they produce a different type of fat cells in the body that help to increase the insulin sensitivity. That help to increase the insulin sensitivity. We will discuss this. These are called peroxisomal cells. The group name is interesting. They are called TZDs. TZDs are thiazolidine dienediones. Thiazolidine dienediones. TZDs. Okay? Maybe difficult. They are also known as glitazones, and one important member of this group is pioglitazone. It acts by different mechanism. It produces or synthesizes new cells in the fat cells, and that increase the sensitivity of the insulin. That increase the sensitivity of the insulin. So that is the big picture of the management of hyperglycemia. First one is replacement. Replacement is directly related with type 1. Okay? Now, insulin. As you already discussed here, insulin receptor substrates, IRS. What is important? This is the mechanism or mode of action that binds to insulin receptors, tyrosine kinase phosphorylation. Intracellular, as I told, that there are certain body organs or systems that need glucose for energy. We need glucose for energy. It is a fuel. But three important organs, again I am repeating, muscles, second one liver, and third one is adipose tissues. Adipose tissues. So, by phosphorylation of this tyrosine kinase enzyme, what will happen that they will help the cells to open and enter the glucose into the cells. Into the cells. Okay. Now, physiologic insulin release. I need your help. Basal and postprandial insulin. Basal. Spectrum synthesis mechanism. Morphing basal? Maybe in physiology. Basal and postprandial. As we discussed in case of cortisol, that the cortisol is synthesized and produced in the body in circadian rhythm, diurnal. Diurnal means morning greater, late night less. Here two things happen in our body when we are not suffering from hyperglycemia. And you know, hyperglycemia means, Dr. Fatih definitely have told you, anything above 126 milligram per deciliter, then this is hyperglycemia. 100 to 126 is pre-diabetes. So anyone below 100, and hope all of you will be inshallah below 100. So below 100 means we are talking about normal situation. So that where the insulin physiologic insulin. So insulin is released in two patterns or fashions. One is that is basal. When we get up in the morning, it start to release. It start to release. And this is sufficient for our whole day. But what is happening? That we have now started taking many meals. Breakfast in the morning. Then when we come here, then brunch, then lunch, and then crunch, and then dinner. So 5 meals at least. Sometimes even more than 5 meals. So when we take that much food, the insulin may not be sufficient. That is released in the morning. So second one, that is called bolus or postprandial. Post means after. Prandial means food. After meal. After meal. So insulin, one that is released in the morning, or what we say unprovoked, you didn't take anything, and naturally the insulin is releasing by the beta cells of Langerhans. The second one is food dependent. You take food, the insulin is released. You take food, the insulin is released. So that is called postprandial insulin. And if anyone in your family, unfortunately, suffering from insulin, you might type 1 diabetes, you might have seen they take injection in the morning, they take also injection before meal, sometimes during meal, sometimes after meal. And sometimes what we say based on event like kapsa, where there is wedding ceremony, there is kapsa. And these people, they have good appetite, unfortunately, who are on insulin. We will discuss this also. So what is happening? They cannot resist. They say, we will take kapsa, no problem. What they do? They say, we will take one more injection of insulin. Why? Because that is postprandial. To cover the duration for which it is taking food. We will discuss this. Okay. That is, goal of replacement is to mimic physiological response. So for this reason, what I told you, will see patient take it in the morning and also with food. Because naturally the insulin is released like this in the morning and also with food. Now look how it will work based on the duration of action. Rapid acting 5 to 15 minutes and lasts for 2 to 4 hours. Short acting 30 to 60 minutes, lasts for 3 to 6 hours. Intermediate acting 2 to 4 hours, lasts for 10 to 12 hours. Long acting 1 to 2 hours onset, and it will go for 12 to 24 hours. So that are the different types of insulin. We will discuss side effects later. First come here. Rapid acting aspartate lisproglulisine or glulisine. Rapid acting means that it will start its effect within 5 to 15 minutes. 5 to 15 minutes. So you might have seen people, they take insulin while taking food. Mostly they are taken in the abdomen region. So they take insulin during food. Why? Because food will go to the stomach and then it will absorb, so it needs at least 30 minutes. While here, it will start its effect in 5 to 15 minutes. Okay? That is also important. All the insulins, they are preferably taken subcutaneous, under the skin. Under the skin. That is the preferable route of the insulin. There is one exception that we will see. There is no oral insulin up till now. Dr. Fatih, like people are working on it, but because they are peptides, they are inactivated in the stomach. But they are working on it. Maybe when you will be teaching pharmacology or biochemistry, your two favorite subjects, maybe it is there. Okay, that is, but right now, no oral insulin. We have insulin, inhaler, Baha, intranasal, Exubera, Pfizer, very famous manufacturing, but still they are in trial. Sometimes it works, sometimes it doesn't work, and mostly they are postprandial. It doesn't give the whole day coverage, but they are working on it.
So the most common route of administration will
Is
be
subcutaneous.
subcutaneous.
Yeah. The preferred route is subcutaneous, except one case where we will see. So, where we will use prandial coverage for type 1 and type 2, and the third one is gestational or gestational diabetes. What I told, that we classify the diabetes into two major groups, type 1 and type 2. There are other like gestational diabetes or gestational diabetes. This is the diabetes during pregnancy. During pregnancy. And in this, the drug that is given, that is insulin. Although it is like type 2, the body is producing insulin. But the drug that is used to manage hyperglycemia during pregnancy is insulin. So we have three indications for insulin. Must type 1, we also can use in type 2, and we also use in the gestational or gestational diabetes. Okay? Second one, short acting or regular insulin. It needs 30 to 60 minutes. It is like our natural insulin. It is like our natural insulin. It is also called regular insulin. Regular insulin. Subcutaneous, but it can be also used as IV. So if you get question on your exam, which of the following insulin is or can be also used by IV route?
Short acting.
Short acting regular insulin. Okay? No other insulin is taken by IV route. Okay. Subcutaneous, we use prandial coverage, same like type 1, type 2 and gestational. IV, where we use IV, DKA, D for drug, K for kidney, A for acute. Disease, kidney acute. Isn't it? You discussed it with Dr. Ayman. Diabetic ketoacidosis. DKA. Diabetic ketoacidosis. Diabetic ketoacidosis. Ketoacidosis means more ketones. More ketones. Whenever more than 3 millimole ketones, that is called ketoacidosis. Diabetic ketoacidosis. Okay, there we use it by IV. This is first IV use. Second one, we use it IV in the treatment of hyperkalemia. Hyperkalemia. What will happen in hyperkalemia? There is increased level of potassium. Anything more than 5.3. Anything more than 5.3 for potassium will be hyperkalemia. Why it helps in hyperkalemia? Because it stimulates the sodium ATPase pump, sodium potassium ATPase pump. It reduces the level of potassium. So there are two IV indications. For example, you get question on your exam. Write 3 clinical uses for regular insulin. Right? 3 clinical uses for regular insulin. So first one, you will write subcutaneous diabetes mellitus. Second one, IV DKA. Third one, IV hyperkalemia. Repeat. First one, diabetes mellitus, 1, 2 and gestational subcutaneous. Second one, IV DKA. Third one, IV hyperkalemia. Was both?
So doctor, the question will be mention 3 uses of regular insulin.
Regular insulin. Yeah, because all others, they are not used in hyperkalemia and diabetic ketoacidosis. Both of them are medical emergencies. And you know where there is medical emergency, what is going on? Yeah, doctor. You detract me when you are looking here. Okay, so regular insulin is used IV, and there is emergency, we use IV. If you remember, in very first lecture I told in general pharmacology, the route of emergency is IV. Okay, go to next. Intermediate acting insulin and pH are neutral. Neutral, protamine, Hagedron, you don't need to recall, but I think you must have discussed with Dr. Fatih. Zinc, protamine and zinc. Yeah, so protamine or zinc, they are added to increase the duration of action. To increase the duration of action, and for this reason they are called long acting. They are called long acting. So it takes 2 to 4 hours. They are intermediate acting, and it takes 2 to 4 hours. But again, subcutaneous only. Subcutaneous only. And where we use basal coverage. Basal coverage means we inject it in the morning and it will cover the whole day. It will cover the whole day. But clinically, many times it is not possible, and we need to take bolus dose. Bolus dose means the dose that is taken with food. Bolus means food. So that is this one. Next is long-acting detamir and glargine. They are subcutaneous only. They are subcutaneous only. Basal coverage, give once or twice daily. Basal coverage again. We take it in the morning and sometimes maybe at dinner time. One thing that you should keep in mind that will help you, as we will discuss in the side effects. Whenever we use insulin, we should play with insulin. Play like we played with local anesthetic calculation, play math. Similarly, we play with insulin. Insulin is adjustable. It is not like paracetamol, fixed dose 500 milligram, khalas. No. Every patient need is different. We calculate the need based on weight of the patient. We calculate the need of insulin based on the carbohydrate intake, what I told. So we need to adjust the dose. Even you will see the patient that they will tell you that I use insulin once in 2 days. Once in 2 days. Why? Yeah, it is possible for the long acting. Why? They use once in 2, because it is based on the food. Diet. If you take food, okay, like we take 5 times. If we take 5 times, definitely we need even short acting or intermediate acting apart from long acting. But if we control our food, our diet, we can reduce the frequency. We can reduce the frequency. What is the problem that we face with insulin? Hypoglycemia. Hypoglycemia. It brings down your blood sugar level like anything. It brings down your sugar level very quickly. Hypoglycemia. And hypoglycemia, the patient is the best judge. He will tell you that I am going to be hypoglycemic. Tremors start, sweating start, tachycardia. What is this? All adrenaline rush. Adrenaline rush. So that is hypoglycemia. Why it is important to be careful with insulin, especially at night? Because many times you might have heard that the patient was knocked at the door in the morning and he was not respond, and he found dead in the hotel room or at home or house or wherever. Most likely he suffered from hypoglycemia during sleep and finished. Because in when you are sleeping, these manifestations don't appear. There is no tremor, there is no sweating, there is no tachycardia. If it is, still you are sleeping, so you cannot realize. So the important thing that we should be careful while using insulin, especially, for example, you don't take food at night, better to skip the dose of insulin. Why? Because if you don't skip the dose, you take the insulin and you didn't take the food, insulin is for your food. So that can make problem. I have seen a patient here in Saudi, mashallah, he was telling that he takes food every 42 hours. After 2 days. He takes food only after 2 days. Every 48 hours and then he will take food.
Fasting.
Fasting like that. For taking milk, taking water but no food.
Snacks.
Like this. For 48 hours. And he was doing very well. He was on insulin. Otherwise, unfortunately, the life, those who are on insulin is not very long. If it is long, still complications are there. Hyperglycemia, you might have discussed with Dr. Fathi and Dr. Ali, many complications. Many complications. The most problematic disease that we have, that is diabetes. Okay, weight gain. One problem with insulin. Insulin is activating our hunger center, hunger station. All the time send message, need albeg, tajij, rest you like. Kudu, huh? Karam likes kudu. Every day I see him, he is standing on kudu. Okay. So anything, and that makes problem. Weight gain, fasting. Second, what is the problem with those who are on insulin? You might have seen anyone who is using insulin. They are advised to carry all the time candies. Why? Because if he is going into hypoglycemia, sudden decrease in glucose, what is given? Sugar. And sugar is, it will increase the weight. So more hypoglycemia, more replacement with sugar, and it will lead to problem. Next is lipohypertrophy or lipoatrophy or dystrophy. As mostly they are taken in the abdomen region, they disturb the fat distribution in the abdomen. Abdomen is very rich in the fat. So when we inject it, what is the problem? That is advisable. We should keep changing the site of injection. We should not take it every day in the same site. Otherwise there will be pit in that site. It will be suppressed. Why? Because the fat will be redistributed. That is called lipoatrophy, lipohypertrophy or dystrophy. The next one is hypokalemia. As we discussed that it reduces the level of potassium, so sometimes it can lead to hypokalemia. So that is the story of insulin. We should stop here or continue? What do you think? Stop?
I think, Doctor, we should stop.
Okay, so inshallah we will next week learn many things.